Thank you so much. I appreciate it. Very warm welcome. I won't take too much time on any introduction because we only have an hour, and this is obviously a topic worth several days of lecturing. So I'd like to give a little quick introduction to what we do from an analog surgery for full arch, a little bit of conversion techniques, and as an intro to several courses that we have and things like that at BioHorizons especially. I'd like to thank BioHorizons for sponsoring me as well to have me here. I've been working with BioHorizons for many years and our Teeth Express program. So quickly, this is our Instagram page, my Instagram page that we use for some of the teachings that we do and some of the cases that we do at our office in San Diego. So you're more than welcome to join it. And I answer a lot of questions on there too as well. So if you have anything to mention, I might kind of dental implant institute that I have where we have mentorship programs and future courses. Hopefully we have doctors that come to our office and spend day and watch us do some live surgery and conversion. So that's a really good thing. And you can message me obviously on Instagram about those kind of opportunities if anyone's interested on more of an individual basis. Our Teeth Express program with BioHorizons is super popular. I think we've been doing it for about 6 years, 7 years maybe. I'm one of the surgical instructors for the analog course with Dr. Ferrier. Our course is about 4 or 5 times a year. We just moved it from San Diego to Long Beach for a little bit better access for people to get in and out. And our other courses in Providence, Rhode Island. These are the courses that you really want to come to have a full several days of lecturing, marketing techniques, live surgery, conversion on a patient, and really go through the full gamuts of what's involved in doing these courses. So I highly encourage you to seek this website if you're interested, and hopefully we'll see you at one of our courses, of course. I'm going to kind of dive into full arch. I mean, full arch is such a hot topic. I've been doing full arch since probably 2009, more extensively now. But, you know, there's so many terms. I mean, we all are comfortable with the word all-on-4, which originally came out with Noble Biocare. But that term really is a non-existent term at this point. I mean, we have all these things on this piece of paper here. You see on my screen here, you know, all on 10, all on 6, teeth today, teeth tomorrow, teeth the next day, all on X, Teeth Express, which is a term we use for our full arch patients in our office. Sometimes everyone has a different term. The marketing for every company that does it, every practice that does it is different. But these are all the same exact thing. That's the thing to remember, that this is just terminology, but this is important for your staff to know as well, because, you know, if somebody calls and says, I like teeth tomorrow, and you do teeth today, it's basically the same thing. So you want everyone to be familiar with these terms, and there's going to be more added, of course. Our goal for doing these treatments is always to provide a fixed set of teeth for patients in one day or the next day or whatever the case might be. We are eliminating a transitional denture, which is a little bit old school fashion way of doing things, right? People get immediate teeth. I mean, I don't load maybe 1 out of 100 arches. So we can find bone. Obviously, we're more of a, in my office, more of a zygoma pterygoid type center, and we do a very extensive atrophic cases and things like that. But you should go with the set of mind that you're going to load cases and give patients teeth the same day. You're not going in there to do surgery and give a patient dentures. This is not what this is about, right? People want teeth these days, you know. If they wanted to have a denture, they could go to anybody else. They want immediate teeth. They can go to a lot of people too, but you want to provide that. Patients are either edentulous, rarely, mostly dentated patients with failing dentitions mainly. So you're going to see a lot of dentated patients in your offices. Rarely do you see denture patients. We're going to use several anchorages in the jaw, 4 and more, of course, to accomplish what we want to accomplish. We want to give a patient some sort of immediate temporary, either an acrylic or a PMMA immediately the same day, or again next day, or whatever the case you might be in your scenario. But they get immediately loaded on the teeth, on the implants. They have teeth when they leave the office. You go through a healing phase. We check our patients a lot during our healing phase. And of course, we deliver them with some sort of final prosthesis, either through my referrals or ourselves, through some sort of zirconia or still, you know, PMMA bar type situations. whatever your preference is for that patient. I'm not going to really get into what final prostheses are. Zirconia being the more popular of the final prostheses, obviously, these days. So that's our goal. That's what we want to do. What we are doing, the process we're going through is we have either a edentulous patient, or we're removing teeth in a patient in the same day. We have to provide some sort of space for this hybrid prosthesis that I call it a hockey puck that we're putting in a patient's mouth. This hockey puck requires space. And now if someone comes in with extensive atrophy of their maxillomandible, you may not have to remove so much bone to create that space. Or if a perio patient with 32 teeth comes in has 90% bone loss, you may not have to trim that much bone away to create that space. But we want to create at minimum of 12 to 15 millimeters. I always say 15 millimeters, the more the merrier, space for this prosthesis to go in for each jaw that there is. I'm going to place implants. As I always tell my own patients, I'm going to do as many implants as needed to provide you teeth. Sometimes it's 4, sometimes it's 6, sometimes it's 8 implants, whatever the case might be. You cannot go in these surgeries. This is why I kind of fall onto the analog side of things versus guided, and I have to do this where I pre-planned it, which always doesn't go as pre-planned, is I go into surgery like any other surgeon and figure things out as I go. I have a plan of attack, but things change when you're in a site. You have soft bone, you have nasal cavities, you have sinuses. You don't know what you're going to do or what you're going to get sometimes. We place implants, we put multi-unit abutments, which I'm going to show you pictures if you're not familiar. This is the game changer for these prostheses, these cases, I should say, where you're placing multi-unit abutments, where you're changing angulation, either a straight 17 or 30 degree multi-unit abutment. The day of the surgery, you torque it down, so everything then is supragingival, and you're working after that supragingival connection on your hybrid prosthesis. You provide the hybrid prosthesis the same day or whatever next day, and again, back to the final prosthesis. That's kind of what we're trying to do. This is a hybrid prosthesis if you've never seen one. I mean, some people in the audience may not know what a hybrid prosthesis is. Hybrid prosthesis is teeth, pink, some sort of pink gums, pink acrylic, pink zirconia, and access to the implants from the lingual aspect. This is not the same concept as doing a single implant where you want that access right on the cingulum of the tooth. You want lingual access to have room for the material to be supported or material to be strong enough. You want an intaglio surface that's nice and clean and convex, and patients are clean, of course. So this is what this requires. As you can see, this thing is pretty big and needs space to sit in a patient's mouth. So that's why we need to create space for it. You deliver that prosthesis the same day. You try to get as great of a bite as possible the day of the surgery. Pretty straightforward, honestly. We do these conversions in 30 minutes, 20 minutes, whatever the case might be with our lab technician. We deliver it. The patient goes home. The temporary prosthesis is thick. It's not as beautiful as the final prosthesis. It has support. You want the material to have support. It has space underneath where the gums can breathe a little bit, it has room for expansion. And then when you make your final prosthesis, obviously it's going to look a lot better and more amazing. Again, some zirconia samples here. And patients love that, of course, and they go on. But there are prostheses. This is an example of a prosthesis where there's a bar inside of it. If you're not doing a full monolithic zirconia type prosthesis, you have a bar inside of it with PMMA wrapped around it, acrylic wrap. We used to do this a lot, back in the days, a little bit more than now. But some patients get this now because of their bite or how old they are, or what's the opposing dentition. So it all depends, of course. But there's certain things you have to keep in mind. You have to have a team approach to this kind of surgeries. You have to have a surgeon. If you are the surgeon, great, you're the surgeon. You have to have some restorative aspect doctor to this event. It's either you or somebody else if you're a surgeon, oral surgeon or periodontist sometimes. And I personally have a lab technician. I have a full-time lab technician that works in my office, and he comes into surgery and sometimes even assists me because we want to see together what we're trying to create for the patient. I tell patients that, again, I don't care if you're a GP, periodontist, endodontist, doesn't matter. You have to be a competent surgeon in this kind of procedure. I'm not really sure what else to say. You have to understand how to deal with bleeding. You have to deal with nerves. You have to deal with sinuses. You have to work with the nasal cavity. These are not single implant cases. So if you're a referring dentist, Pick somebody that you're very comfortable and is confident to do these kind of cases. I would tell you that most of my fixture cases at my own office, I fix a lot of cases, are from surgeons, like oral surgeons and periodontists. I mean, it doesn't mean just because you're an oral surgeon or periodontist, like I'm an oral surgeon myself, that you do these right. I mean, you have to understand the concept of it. So again, qualified lab technician, qualified surgeon, you have to understand bone reduction and how to remove bone. And this is the step that's going to separate you from others. You know, if you don't get that right, then it's a nightmare from this point on, obviously. And obviously implants and the multi-unit restorative things, that multi-unit abutments. But, you know, again, patients in your office, you see patients like this, you sit down, if you don't have in your head as part of your treatment plan a hybrid type prosthesis, you may look at this patient and say, look, I'm going to try to fix some of these. I'm going to do endocrine. That's fine. These are treatment plans. I'm going to do a couple of implants. Or you get to a point where it's extensive enough that you say, look, we've got to throw out a couple healthier teeth. The rest are bad. We're going to give you a fully new set of teeth, new life, and maybe at a lower cost. So, you know, we're not in the business, like as I said, in the business of taking out healthy teeth, but but sometimes you have to take a couple out here and there. Some that can be fixed, but you have to look at the overall thing. You have to look at the patient's desire of what they want, you know? So that's kind of very important. Like, what does the patient want to do? But, you know, we look at cases here. I mean, obviously to me, this is a very straightforward situation. You could come in and say, look, you know, you have bridges, you have, you know, a number 15 that's, you know, that endo treated. We can do sinus grafting, single implants, veneer the fronts, crowns the front, posterior mandible is going to need some extensive grafting possibly. I mean, these are the cases that when you go through that kind of treatment and years that's going to get you there, is it easier to sacrifice a couple of teeth and get to that final result more immediately? This is why this is so popular right now. This is kind of what, you know, patients, especially patients who don't go to the dentist that much, are in favor of doing these kind of cases. You know, you look at a patient like this, I show you the x-rays. I mean, these are not PA x-rays, so I can't fault you for not seeing what's going on here. But, you know, you look at this panel, you're like, well, what am I supposed to do with this? I mean, you have a little bone loss on the lowers, anteriors, some cavities. Well, let's see the patient. What does the patient look like? And you look at the patient, and this is somebody who has gone through a lot of issues, maybe, you know, dry mouth, this, a history of drug, whatever it is, you know, and you look at it and like, well, I can't, you know, what are you going to do here? You know, again, we're not in the business of just pulling teeth out, but at the same time, it's like, what can you deliver to this kind of patient? How old is this patient? What can we do? So these are the patients that sometimes you say, look, you know, this might be a better choice for you. You have the adequate bone right now for us to get some nice and healthy implants and get you out of these diseased teeth and move on to a kind of a more of a hybrid type prosthesis. This is extreme, obviously, but I'm kind of just trying to make a point here, of course. Again, this kind of touched up on, you know, is it, again, you know, we're talking about good teeth, bad teeth. Is it ethical to take some of these? Who's, you know, is the patient's desire more than what we decide to do? I mean, obviously, this is a combination of things that, you know, we want, you know, a professional's opinion and a patient's desire, you know. But once you commit yourself to these cases, I mean, you have to understand, you're taking out teeth, you're taking out healthy teeth, and then you're committing yourself to bone reduction and things like that. You need to deliver. You need to deliver teeth to the patient, and dentures are not an option for these patients. So it becomes a little bit of a big burden sometimes on doctors' shoulders. Now, I use a lot of BioHorizon implants. Obviously, I love them. You know, we got the Tapered Pro system that we use a lot, different sizes. I'm not really going to get into this too much, but if you don't use BioHorizon, it's definitely something to look into. Beautiful stability and the laser lock system, and the multi-units are amazing to use. Different angulations to those, of course. What I consider, you know, for any case, you got to decide, you know, you look at the CT scan, you say to yourself, am I tilting implants? Am I placing implants straight up and down? Do I have enough bone to do such things? Can I provide enough adequate, you know, prosthetic space? Am I going to do a guided surgery with freehand, which is what we're talking about today a little bit. We talk about implant lengths, the AP spread being one of the most important aspects of these cases. How can I obtain more AP spread? And do I need more number of implants to do such a thing? Bone reduction and medical history and all those things we talked about. But those are the things you want to think about before a case, of course. Now, when we talk about specifically about the number of implants, you got a situation like this where you've got, I don't even know how many implants in there, but there's reasons for that. You got to look at a patient and say, is there parafunctional habits? Is there opposing dentition that you're concerned about? Is the qualities bad? Is the quantity of bone bad? Am I going to get the AP spread with just a couple of implants? Or medical conditions such as this patient you see who has osteoporosis. Osteoporosis patients have very soft bone. So, you got to figure out, again, beauty of analog surgery is that you kind of have to figure out where you can put implants to complete the case. I put a lot of implants in this patient because implants are spinning. And so, I use molar implants, shorty implants, pterygoid zygoma implants, whatever we can obtain to obtain proper torque value to deliver teeth to the patient. So number of implants, again, doesn't matter to me how many implants you use. Are you achieving the same thing? Are you achieving the same AP spread by putting 6 implants as 4 implants? If the answer is yes, then you should raise the question, why am I putting 6 implants? If you have 6 implants that are nice and strong, 4 implants that are nice and strong in a mandible, do I really need a midline 5th implant just to make myself feel better? There's studies that show a midline 5th implant has 0 bearing on it. So you always have to think about this. You can't just go into a surgeon and say, I'm going to put 5. That's it. That's what I'm going to do. That's not the correct way to do it. Now, AP spread is probably the greatest thing you need to think about when you're doing surgery. Again, I always say it's weird for an oral surgeon to think about AP spread all day long, but this is what I'm doing when I'm doing surgery. It's like, how can I get access holes in the molar, second premolar location so my patient has teeth up to the first molar? How can I deliver this for my restorative doctors to have good AP spread? If I can't deliver it, then I've failed. If you put an implant that comes out even with 30-degree multi-unit in this first premolar location, that's not enough AP spread. That's not going to do the job. So that's really important. You got to think about yourself how you're going to do that. We talk about tilted versus axial implants. People always ask me, why are we tilting implants? Why can't I put implants up and down straight? Again, comes back to AP spread. If I'm going to angle implants to avoid vital structures such as sinus and nerve, I'm angling it to gain more, not to only miss those vital structures, but to gain more AP spread. If I didn't, like for example, that upper left example, if I didn't tilt that implant, I put the implant up and down straight in front of the sinus, my AP spread was going to be low. In the lower picture, you have enough bone below the sinus floor to put implants axially, right? So the result is the same. How can you achieve the same result? You have to tilt or be straight. So again, it's a question that comes up a lot. There's a reason why we tilt implants, to avoid certain things and gain AP spread. But if you can do implants straight because patient has tons of bone, fantastic, awesome. Go with it, for sure. But we tilt implants in all sorts of directions. We tilt implants in the canine fossa. We tilt implants in the pterygoid region, in the zygomatic bone, to achieve these kinds of AP spreads that we want. Look at crazy cases that we do like this, where this is all sorts of implants. We have an impacted canine number 11. I got a zygoma going around it. I have a pterygoid on one side to support that zygoma. I have a pterygoid on the other end to support my other implant. We have a transsinus implant. We have a vomer implant. Every sort of implant that could be possibly done in the maxilla is done in this case to achieve the same concept, to achieve the AP spread that I want to gain for the patient, of course. Zygoma implants, we are probably one of the premier zygomatic offices in Southern California, I would say. And we do these things on a daily basis in my office, and this kind of implant is a game changer. It has become more popular recently. Obviously, oral surgeons have known about zygoma implants for a long time. It's very technically challenging, but it does allow you to get so many more cases done. Also with the addition of pterygoid implants, which are super difficult too. But these are kind of some of the cases that we're doing to gain access to the sinus and not have to do any sinus grafting. This is a complete bypass of any sinus graft. You can see how pneumatized sinuses these are. No more sinus graft, waiting 6 months, coming back, placing the implants. These are like old school ways of doing things. So we don't really do that ever. You get an atrophic maxilla, and an atrophic mandible. Did this case with my partner, Dr. Evans, recently. But very, very, very atrophic maxilla. This is a quad zygoma on both sides. Quad zygoma, very technically challenging, especially in a situation like this when you have zero crestal bone for support. And these cases delivered, I mean, this patient, is in a denture that doesn't stay in, of course. She has no palate, of course, and we're able to deliver teeth to these patients and get them out of a denture. So that means a life-changing experience, honestly, for everybody. We have a zygomatic course that I do with Dr. Sean in Long Beach, California, at the 4M Center. If anyone is interested out there on zygomatic implants, pterygoid implants, transinus implants, we have a good, solid cadaver 2-day course in Long Beach. You can visit the 4M Institute to obviously sign up for those cases, for those courses, I'm sorry. Now, when I do freehand analog surgery, everyone asks me, well, do you have a guide? Do you use anything? Of course, there's a guide. There's a planning that goes into it. We have a workup. We make a denture. Everyone knows how to make a denture. We figure out what the incisal show is. We figure out where the bite is. We duplicate that denture, and my lab technician makes a guide for me. The guide provides me certain information. It provides me the amount of bone reduction that I have to do, and it provides me an area to figure out where the multi-units need to be placed or come through to be successful in the case. These cases, these guides can be printed now with the advent of more digital dentures and things like that. You can digitally print these. You can do these in the office setting with different printers. You don't have to duplicate anything, but regardless of how you make it, the concept is the same. You have we teach in our Teeth Express courses a line that I draw on these guides to show my bone reduction, and then areas where we place multi-units and see how we can deliver the case to the patient. But basically, the duplication of the denture, as you see, we figure out where our 15 millimeter bone reduction is. In the double jaw, it's 30 millimeters of minimum of space there, and we replicate it on the guide and we put it in the mouth. So it's not a guided surgery, but I have a guide for my analog surgery to get the case done. And those are the information that I really need. This is in a patient's mouth, where I have it seated in the palate, check my bone reduction, check the placement of the multi-units, make sure they're coming in the right direction with the 30° 17 or straight. We check the front ones, we check the back ones. And this is all we need. This is what I need to make sure that my restorative doctors can deliver proper hybrid prosthesis to my patients there. And hopefully you get a situation like this with an amazing AP spread, right? These are optimal positions for access holes to come through in a hybrid prosthesis. Not every case, of course, turns out this way, but at least this is what we're shooting for, of course. I'm a little biased because, I mean, obviously I've done a lot of guided surgery, whether it's N-sequence or all those different things, but I'm an analog surgeon. I call myself an analog surgeon because I like to get in there, open things up, then decide what implant, what type of implant, what do I need to do to deliver what I need to deliver. That's kind of the gist of it. The other good things, advantages of analog type surgery is that you always have to have a lab tech with you. I mean, who doesn't want their lab tech with them? Most of these guided cases, they say, you don't need a lab tech with you. Okay, I mean, that's fine, but things don't go always right. And do you want to go sit in the lab and do work? Is it less accurate? So yes, around the vital structures, a little bit less accurate, but once you get the hang of it, it's pretty straightforward. But again, less extensive surgery. I don't have to raise as much flap, faster surgery time, more tactile sensation, which is probably the most important thing because I can feel the implant going. I can feel the torque that I'm getting. I can't tell you how many guided surgeries I've performed where I've placed the implant and it's like soft bone. I'm committed to that osteotomy. Now I don't want to say a bad word on the computer, but I'm done. What am I going to do here? That implant is unusable for the day of the surgery. And of course, it's less costly, which becomes a big situation in most patients. But, when we take these steps, the first thing that we want to think about is, I want to have a guide that shows me bone reduction. How can I obtain the bone reduction? You can look at these on the CT scan initially. If you look at the incisal edge and, I ask my lab technician all the time, hey, have you changed the incisal edge on this patient? No, it is what it was before. Great. So 15 millimeters from the incisal edge is where the bone reduction technically is. That's 15 millimeters of restorative space. So I measure that before I remove teeth in the mouth. I mark it. I put my guide to double check it, and then I reduce the bone in that area. So that's kind of just checking yourself, make sure the guide is right. And then when I'm reducing the bone, we cut away the bone. I mean, we're not sitting there with an acrylic burr, for 45 minutes and dust coming everywhere. We cut the bone. that's where the bone needs to be cut. We're going to cut the bone. So you can see some of the examples here of us removing bone. Here's an example of teeth out already. We cut the bone out from retromolar to retromolar, from the maxilla, from tuberosity to tuberosity. I want a nice flat plane, a nice buccal shelf there, and almost a 90-degree. These are not denture cases, so you want them to be nice and a 90-degree angle. You get cases like this. I mean, if you look at this patient, 80-some-year-old, endo-treated teeth, every single person who's watching this, myself included, would break every single one of those teeth. Who wants to sit there sometimes and remove, broken root tips? So in those scenarios, hey, we mark where the bone reduction is. I cut. This is called the alveolectomy with the dental segment. I call it. This is a little term that I've came up with. I cut the area away. I'm left basically with this almost hemimaxillectomy here. And then you look at this. Look, every one of those roots are endo-treated. This root tip remaining is much easier to remove than trying to remove the tooth as a whole. If I tried to remove the teeth as a whole, I would destroy the buccal plate on this patient. There would be no buccal plate. This way I can preserve it, use my periotome techniques, just get these, or root banking sometimes that we do in some of the canines, for example, or molars even. And these are the things that we do to preserve the architecture of the jaw. Another scenario here where you have failing dentition that are going to break while you're trying to remove teeth. Here we again measure down in the mandible, we remove it, and this patient happens to have tori. So a lot of patients have tori. We have to remove the tori in patients. And as you can see, we can almost cut it away all at once and then just remove the root tip and do a little bit of alveoloplasty. So this is another technique to get ourselves in and out of surgery a lot quicker by removing this bone. And sometimes, again, as I said, patients have tori. These are kind of similar images that come out of some of our bone reduction techniques here that we do in our office. And it becomes a much more faster surgery and clean surgery than trying to do alveoloplasty, with acrylic burr. But what you don't want happening from a bone reduction standpoint, all these images that I have here up here for you, I borrowed some of them from my friend from the Implant Ninja, but these are images of cases where bone reduction was not done properly. You have a prosthesis with a bar that's breaking. The reason it's breaking because they don't have room to wrap enough acrylic around the bar. That's plain and simple. It's gonna keep breaking. You break the temporary, you make the temporary in the posterior region because you didn't do bone reduction in the posterior mandible. Very simple, or the maxilla. Or the worst case scenario, when a patient smiles, you see this junction between the restoration and your natural gingiva. If you have this situation, this is 100% of a failure. You cannot have that. So you have to take this consideration. This is why we take pictures from the patient. We have a workup. We took picture. We put the patient's picture in the surgery room to see where's the smile line. Well, how much do I have to take this prosthesis off? These things cannot have flanges, right? There's no flange like a denture. So you have to be, to even see if this patient is a good candidate for this. Let's look at a couple of different scenarios and cases. These are like in the surgery day. I come into the surgery, I measure, I measure my lab tech's work. It's good to double check things. I have a guide, always check to have a guide ready at the beginning of the surgery. You open the flap, you mark your bone reduction, sometimes more than less, depending what your guide is telling you to do. We cut the bone away. We check with our guide to see if our bone reduction is correct. I always go above that line that's on the guide to make sure I have good bone reduction. You want to preserve all of that canine eminence, all the bone that's creates the patient's architecture in their face. You remove all of that. It's not a denture where you're going to have this flange where it gives you lip support. You have to have the bone give you lip support and cheek support. So you don't remove those. Those are, even though they look like sharp ledges there's no prosthesis sitting on it. It's not a denture, right? It's an implant-borne prosthesis. You're not going to have problems with that. Keep the architecture, keep the canine eminence there, and we go from there. But what I was saying is that we angle the implants around the vital structures. By the time you've done bone reduction, I don't want to give percentages, but most of the time, posterior maxilla and mandible, there's not enough vertical bone to put axial implants. So we tilt implants around the sinus and we tilt implants around the mental nerve, especially the anterior loop of the mental nerve. And if you look at an X-ray like this, we want to know where the nerve is. We want to make sure that the loop doesn't come too far forward. We expose the nerve at the time of the surgery And in our courses, I teach you how to avoid this nerve. And that's something a little bit more extensive than tonight. But at the same thing on the maxilla, I look at the sinuses. Where can I start my osteotomy? Where can I tilt the implant to not enter the sinus floor or get into the in the nose, the nasal cavity? But anyways, we move forward. We place bone reduction done. We angle implants. We place the implants very palatal. You can see some of these pictures where implants are placed behind where the sockets used to be. They're not, look at the buckle. I mean, really, look at the buckle width. That's crazy, right? But you want it as palatal as possible. BioHorizon has this amazing implant, the more multi-unit replicas where you can figure out your angulation and the rotation of the implant prior to opening up your multi-unit abutments. So those are what you see inserted into the implants there. Again, put the guide back in, make sure you're coming out through that trough in the back where you want it to come out, where your access holes are going to be, and you're comfortable with that. And then you move on with placing the multi-units. These are the little healing caps that we close around. We use a lot of PRF for our closures when we do these surgeries, especially like we have grafting going on and we place graft and we put PRF on top of it. We're big PRF users in our office. And you can see here, we place it for just healing purposes. And I mean, I'm not going to get to PRF right now, but it works. It's amazing. If you're not doing it, something definitely to look into. Of course, we close the case. It takes me sometimes longer to close these cases than do the whole surgery, mainly because I want to pay very nice attention to this tissue closure. I want it to be clean. I want it to be resorbable sutures. I want it to be able to be bloodless. I want my restorative dentist to come in here after me and take these, put these cylinders on or these caps off and have no tissue covering the multi-unit abutments. This takes a little bit of time. I hate when I see surgeries or pictures that people put one suture between each one of those cylinders and call it a day. I mean, all of us can do that, but it's not clean. It's ugly, It's not going to have a nice, smooth, intaglio surface to the prosthesis. Take your time, close the case properly. We have different techniques that I use now to increase the vestibular height, especially in the maxilla, and give patients extra keratinized tissue by using the palatal tissue. You can see how thick this tissue is right now. It works amazing. And here we are putting some copings on, picking up the case in the mouth and delivering the hybrid prosthesis and putting temporary seals in there. And of course, you have a nice clean intaglio surface. You have good spread, hopefully, and you deliver it to the patient. You have the patient smile. You don't show that junction. And that's kind of what we want to end up at the end of the day for a patient with a nice bite. So that's kind of the case. I walk you through a case and then we get to some questions here, kind of see what we are doing here. You have a patient, young patient here, several broken crowns, some are failing posterior teeth, upper left side missing teeth. We talked about sinus lifts. She just couldn't go through that price. That the maxilla would have cost about $60,000, $70,000 with all the crowns and veneers and gingival contouring and sinus graft. So she decided for the full arch case, we want a pretty lady, we want to deliver something. I look at the x-rays, not necessarily the simplest case. There's some pneumatized sinuses, but I'm confident we can angle implants. I could even go to her pterygoids if I wanted to, specifically in the maxilla here. We did her mandibular surgery later on. When we proceeded to surgery, here's some videos of us raising the flap here. You don't want to leave the papillas around because you're going to cut them later, of course. But you make a nice smooth incision. You raise a nice flap. I expose the nasal floors. We remove the teeth. If the teeth are loose, you take them out. If they're not loose, then maybe do some alveolectomy around them and then remove the teeth. Again, I measure up 15 millimeters or so before I remove the teeth to see where I want to reduce. Again, tuberosity to tuberosity, we want a smooth, clean line or flat plane of bone reduction going all the way to the tuberosity area. So here's our flap elevation finishing up here. You want to take some good care on the flap elevation, especially on the lingual surface and the mandible. Make sure that periosteum stays intact so you don't have the sublingual gland or anything like that come into play. And that's our flap elevation. The bone reduction, again, we have the guide. I place the guide in the mouth. We have a nice implant retractor that we use. We seat that in the palate. That's the reference point. I mark. I mark the bone level that I'm reducing here. You see, I'm standing behind the patient. I'm marking it. I'm confident about that. Finish the markings. I'm going to use a simple Fisher burr. These are kind of straight hand pieces. And I just cut it away in about 30 seconds and it's over. And again, as you come to our courses, we teach you how to reduce this bone, how to avoid the sinuses on your reduction. We still take a little bit of a, rongeur or acrylic burr at the end of this to just smooth out the edges. You don't want sharp edges everywhere, of course. A little old-fashioned removing bone with a rongeur, but some acrylic work just to kind of get it smoothed out. But I'm not reducing, 5-6 millimeters of bone with just acrylic burr. That's just a little bit of a nonsense. But then we mark where I want to place the implants, where I feel comfortable, the sinuses. You can even see a little sinus exposure from my bone reduction there. We fixed that during the closure. But doing the osteotomy as palatal as possible. I don't come in the sockets usually to place the osteotomies here. So you can see us doing some of the osteotomy techniques here. This works out really nicely, actually. I use a perio probe to feel those osteotomies, to, again, tactile sensation, to make sure I'm not in the sinus, to make sure I'm not in vital structures of the nasal floor. You have to have a perio probe on your kit. I'm probably the only oral surgeon that has 200 perio probes at their office. Again, the other thing that you have to concentrate on is how much under prepping you're going to do. With the advent of Versa burrs and things like that, there's got to be some sort of under prepping done when you're doing these osteotomies to make sure the implants are not spinning. And the beautiful thing about BioHorizon is we have so many size implants, I can just go a size up. I can start with a 3.8 implant with good torque or really terrible torque, and then I can switch to a 4.2 or a 4.6 or a 5.2. I mean, I have so many different options on my BioHorizon system to do what I want to do. But, we place the implants, we torque them down. I teach you again in our courses how to place these implants subcrestally a little bit to make sure that, to account for some of the future bone loss in a way. Then comes the fun part of placing multi-unit abutments. Multi-unit abutments, initially, you want to practice this if you haven't done it on a model to understand how these go on and how you want to put them on. But you can see we're putting 30-degree multi-units on this patient because I placed my implants at 30-ish degree. And this allows us to kind of parallel the abutments, have them coming into the right direction. This way, the hybrid prosthesis seats very passively on these multi-units. You can see how, here's one of the make a note of, look how palatal I placed the front implants in this scenario, and we still put angled implants, angled multi-units to take it further back. Because if I put straight multi-units, it would have been too close to the incisal edge. It wouldn't allow the lap tissue to put enough material in that area. So very critical with these multi-units and how they've kind of changed the game as to what we can do, what we cannot do here. Grafting, people always ask me, is it a graftless type of thing? It's graftless in the sense that we're not doing extensive sinus grafting. But I still graft the sockets, I fill them in, I put some membranes on them, you put some PRF on top of it. Lately, I've been using the BioHorizon allograft putty to fill in some of these guys. It works really, really nice. If you haven't used it, check it out. But you graft the holes, the osteotomy, not osteotomy, I'm sorry, the sockets if it's necessary. And then you start closing. You start closing and you take your time. You trim tissue. You maintain that buccal keratinized tissue as much as possible. Multiple interrupted sutures. People are like, why aren't you running this suture? Why aren't you? Trust me when I tell you, I've tried this in multiple fashions. Between the implants, I put interrupted sutures in the posterior maxillary mandible. You can run it. There's no implants there. Who cares? But look, I finished the surgery and this is a nice, clean field. I give a little local. I hand it over to my restorative doctor where they can kind of take over and work in a very bloodless field. Imagine you have to put cylinders on top of this. You have to pick up the case and move on. Once I get to this stage, the restoration starts. Now, whether it's yourself, you're handing it over to a restorative doctor, you're handing it over to the lab technician. This is the analog way we do the hybrid. And honestly, I love the digital techniques that are out there. We're going to go digital at some point, of course. But this analog way, you have to understand, you have to do it first. You have to, understand it and be comfortable with it, and then move on to other things. And honestly, we do this so fast that sometimes I'm like, do we really need to print temporaries? I mean, we're so good at it and fast. Quick couple of steps. You take the denture that was made. This denture was pre-made, with the tooth show and incisal edge and all that. You blue mousse, you index those healing caps. Those things that are sticking through are sitting on top of the multi-units that are in there. They're little tiny healing caps. You index that in the back of the denture, right? Pretty simple. Blue mousse it. My lab technician, within a couple of minutes, opens up those holes. If you have implants in the anterior that are close to each other, you just open the whole thing. You just gotta, give yourself some room. While he's opening that up, I've already put in cylinders in the mouth. So I take those little tiny caps off. I put 5 cylinders here in this scenario in the mouth. I put a quick rubber dam on top of him so the acrylic doesn't get on my stitches. And he walks in, hands me the denture. I put it on, make sure I have good, clean, passive, there's nothing touching the cylinders. He hands me an acrylic material, and I go around the cylinders and I pick up the cylinders in the mouth. The palate being, again, the reference point, or the lower teeth, if they're remaining, that's the reference point, right? So we just retrofill this with acrylic in the mouth. It doesn't have to be pretty. All we're trying to do here is just pick up the cylinder. 3 minutes later, 4 minutes later, the acrylic is done, it's set. I unscrew this, I take it out of the mouth, hand it over to my lab tech. I make sure the cylinders are not moving. They're nice and tight. And I put the little healing caps off, and he's off to the lab to trim this. And 30 minutes later, he comes back. Again, this is more of a lab work here. He's doing retrofilling some more acrylic. We always make a cast. So we have a cast in case the prosthesis breaks. We can put it on the cast and fix it. I make sometimes night guards for the patients immediately. So we do that at the same time or beforehand, like a 4 to 5 millimeter thickness, soft night guard. So this is a little bit more lab work.
Tap, tap, tap.
And we deliver this to the patient. We deliver to the patient, make sure we got the bite perfectly.
Open and close. Close.
You can see in this patient,
Close.
minimal bleeding at the time there. Some breathing room. I want you to notice that I see my stitches. I want some breathing room. When I give this back when I get it back from my lab tech, I say, look, I want some breathing room there. I want initially room for the expansion of tissue and then have it recede back. You can always come back and add acrylic, but this allows the patient to learn how to clean under the prosthesis in the temporary phase. Once you give the final to the patient, then it's nice and snug with the tissue. And by then they've learned how to clean everything or use a water pick and know how to use it. And that makes things a lot easier. But, we take patients and we take them from these situations and some of the dental nightmares that they've been involved with. And of course, you transform these patients. She finally got her lower teeth, of course, to something really amazing and beautiful. Honestly, some of these cases are life-changing, not only for the patient, but also the doctor. So if you've done these, you know what I'm talking about. If you haven't done these, you do want to incorporate these into your practice, of course. Seek some of the courses that are out there. The Teeth Express courses are great, of course. But I encourage you at the end of this to learn all of this, the more analog way of doing things. Once you're comfortable with that situation, you can certainly pick up where you're comfortable with and do some guided cases and or go back and forth however you wish. But at least when you go to a guided situation, if something goes wrong, if things go wrong, at least you know how to pick up from there, pick up the pieces, analog, and fix the situation and deliver teeth. I think I'm going to end it there. I know this was a short and sweet type question situation, just a little quick overview, but I want to leave room for any questions that people have. So some of the questions that come up: what do you use for an alveolectomy? I use personally. I've tried all different ways of doing this. I've used a reciprocal recip saw. I've used piezo at times for this. But honestly, at the end of the day, a simple 703 Fisher burr in a nice handpiece that can cut through bone is probably your best bet. If you're using more of a dental surgical burr, you want to make sure there's no air going into the surgical site so you don't have any tissue emphysema and things like that. So that's kind of what I use for my alveolectomy. I take the acrylic burr afterwards, and of course, I smooth the edges down a little bit. So that's where the acrylic burr comes in. You can try different routes, but this seems to be the most easiest way to go. Question about teeth are acrylic or porcelain. Teeth are initially acrylic or some sort of PMMA material. If you're printing these teeth, the PMMA material is probably the way that happens. We use, you can use digitally printed dentures, but basically initially from a simple standpoint, it's a denture, acrylic, and then that's transformed into the temporary. The finals are more of a zirconia material or a bar with acrylic or other things that might be out there. Pardon me. So it depends. When you're talking about the finals or the temporary, that's kind of the different things we use. Again, from that, the denture that we tend to make, we want to make sure that the acrylic material is a strength. The newly digitally printed dentures are really amazing and strong. I mean, they can last you for a very, very long time. I'm going to skip that one question and go back to the person that asked about the denture. He's saying, is the denture still retrievable or removable? Let me ask you first. It is not a removable denture, right? Once we converted it. Once you converted it, it's screwed into the multi-unit. So it's 100% retrievable by removing 4 or 5 little tiny prosthetic screws. You cannot do these procedures with a cemented fashion. You sometimes take out these old cases and redo them, and the full arch hybrid prosthesis is cemented onto abutments. I mean, that is just a nightmare. I recommend these prostheses come off once a year. Once a year, take them off. You take them to the lab, you clean them up, you check the tissue on the patient, you take a couple of x-rays. In fact, twice a year, maybe sometimes. But at least removing the prosthesis, which takes 5 minutes. I mean, we remove prosthesis all day long in our office. So it's very retrievable. It is not a removal by the patient type of prosthesis. That's it. Let's see, what else we have here? We have a question about the nasopalatal neurovascular bundle and when I do my bone reduction. So I take all the care to preserve that neurovascular bundle, right? That neurovascular bundle, in all honesty, provides sensation to a very small area of the anterior palate. If it does not there, usually patients do not complain about it. Now, I'm not saying I go in there and cut it. Now, there's some atrial fit cases where we have to get it out of the way. If you're going to cut it, it's best to cut it with a fresh blade so that some of the neurovascular bundles go back together. You do not want to take a burr and hit this nerve or empty the nasopalatine canal by burning it or putting an acrylic burr in it. It causes trauma to this neurovascular bundle, right? So what I do is when I'm raising the palatal flap, I expose that nerve, I look at it, and if I need to move it out of the way, first of all, I protect it when I'm doing my bone reduction. You can actually move it more palatally by removing some bone around the canal and pushing it more palatally to get it out of the way a little bit, like transposing the nerve a little bit to a different area. So my goal is certainly not to damage it. If you have to get it out of the way by cutting it, cut it with a blade, but definitely do not traumatize this nerve. It could come back and haunt you later, for sure. Okay, let's see. Now, question here, good question. Why do you start with the upper arch? You always want to start with the upper arch because this goes back to like orthodontic surgery, denture making, whatever. The palate is the most stable point. Once you remove teeth, you're losing all your stable points, right? So the palate, the way you made the denture, becomes your stable point, the only point you have in an analog surgery. So I use the palate to fix the midline initially, to seat the process properly so my incisal edge is correct when we planned it, pick that up, secure that upper. So that's why we do the upper conversion first while I'm doing lower surgery, and then set the lower teeth to a fixed upper teeth. It is a much, much easier way to do it. Now, some people start with the lower, they want to go, they have different ways of doing it. But if you want to just make it easier in your life, that's the way you want to do it. Create a fixed upper set of teeth and then set the mandible to it, of course. Now, it says, are you giving anesthesia, right? Anesthesia is very important. Doing these cases under local anesthesia, I shouldn't say always, most of the time, is unbearable for the amount of work that we're doing, you know? Personally, I mean, obviously I'm an oral surgeon. I sedate people all day long for different procedures. I've sedated numerous people for these kind of cases, hundreds and hundreds and hundreds of cases. But most of my cases, I actually get an anesthesiologist. You know, that's kind of what I do. I do 3, 4, 5 arches a day sometimes. So we want an anesthesiologist where the patient is protected, the surgery goes more smoother. You know, I just tell I always say in my courses, I tell the patient, hey, when you get your appendix out, do you go to sleep? You know, yeah, I go to sleep. Great. So we're going to sleep for this case too. But if you're very comfortable in your sedation techniques, you do oral sedations, you can get the case done, do whatever is necessary to do it. But obviously, it's very nice to have an intubated patient with the airway secure, there's blood, bleeding, all those different things going on. So I highly recommend having some sort of anesthesia there. But, you know, anesthesiologists, dental anesthesiologists are very prevalent around the country. You hire them. I have the patient pay them directly. Some people incorporate in their fee and they pay the anesthesiologist. Whatever is going to make your life easier. Now, I would tell you, if this is your first couple of cases doing it, have an anesthesiologist. You know, things are going to get a lot smoother for you until you pick it up a little bit. Let's see. Let's take another question here. Water pick, recommended for cleaning. Water pick for everybody. I start water pick at 4 weeks. You know, the first couple of weeks, they do rinsing, just rinsing their mouth, Paradex, salt water, whatever the case might be. Then we do a syringe rinsing for an extra couple of weeks to get that syringe where the stitches, the sutures are. And then once the sutures have dissolved and the tissue is closed completely, they move to a water pick. I tell them water pick for the rest of your life. You have to clean under this. I mean, I don't care if you don't brush your teeth on a nightly basis with a soft bristle toothbrush, but you're going to water pick your teeth every night. You know, water pick the flange, the space between the restorative component and your gingiva. That's where things gather. That's where peri-implantitis will happen if they don't clean. They have to use it. This is why I recommend, in fact, I void people's warranty if they don't come back and show themselves 1 or 2 times a year. So you can see what their progression is. What is their hygiene? What are they doing? You know, if they disappear on you, they never clean inside their mouth like their old habits, then everything's going to fall apart. There's nothing you can do. So that's that. Question is here, I said resorbable sutures. I highly encourage resorbable sutures. The reason being that if you use unresorbable sutures, nylon, I hope you never use silk, but if you're using silk or other things like that, you have to remove the prosthesis in the temporary phase to remove sutures. You can't always sneak under it to remove every suture, right? So why would you want to remove a prosthesis in the temporary phase if you don't have to? The temporary is there, it's secure. You don't want to take it in and out. You want to leave it there, especially if your implants are a little bit unstable and things like that. That's cross-arch stabilization of the implants. Let it be for this first several months. So this is why I use chromic gut sutures for within the first 2 weeks, they're gone. Now think about it this way. I use Vicryl sometimes in my bone grafting cases because I was going to get that nice tension. I want to keep it there. I use nylon sometimes. When you've removed 4, 5, 6 millimeters of bone, the tissue closure is, you don't even have to do periosteal scoring. The tissue closure is 100% tension free. All you need is a couple chromic gut sutures, and more than a couple, obviously, as you can see. But that's why I use resorbable. It's tension free. You never have to worry about tension opening this flap up. And I want my sutures gone in 2 weeks. I want it gone, you know. I want it gone from underneath the bridge so they can clean it. My tissue's closed by then. And thus, I recommend the resorbable sutures for sure. I mean, it's a nightmare if you're using unresorbable sutures under these prostheses. Anyways, if anyone has any questions, go for it. If not, then we'll try to wrap it up here.